Anyway, we will start here today with a great case presented by Dr. Ferrandes, fellow imaging CT, MRI imaging fellow. And we have a great panel, actually great case. Great case, hopefully learn a lot. We have a great panel. Dr. La Roca, who is the associate professor and co-director of advanced cardiac imaging. We have Dr. Contreras, who came late last night from a trip. He came fresh early here today for this meeting. He's a professor and heart failure and transplant team. I will be one of the also people in the panel. And Dr. Gilbert Tang cannot be here, but he will be here about his brain as something came up because of the Sky meeting that is going on through the same time. And we have a great moderator, Dr. Beanstalk, who will do a great moderation. So we're ready to start.
Thank you for that. We are going to present today this interesting case. It's a 66-year-old woman presents with shortness of breath and heart failure, with past medical history, cardiovascular history of heart failure with reduced ejection fraction, and ischemic cardiomyopathy, likely adrenaline-induced, severe tricuspid regurgitation, pulmonary hypertension, group 2-3, and with other history of chronic obstructive pulmonary disease, home oxygen, Hodgkin lymphoma, thrombus of the right jugular vein treated with Eliquis, bleomycin-induced pulmonary toxicity, and got the home medication is pantoprazole, Entresto, Farxiga, Arbedilol, and furosemide. In the physical examination, the patient has normal appearance, mucous membranes are moist, oropharynx is clear, normal rate and regular rhythm, normal pulses, normal heart sounds, no murmur heard, lungs, pulmonary effort is normal, normal breath sounds, no wheezing, normal work of breathing. The abdomen is flat, vocal sounds are normal, there is no distension, abdomen is soft, there is no abdominal tenderness, extremities, no swelling or tenderness, and normal range of motion, and no edema. And the patient is alert and oriented to person, place, and time. Here we have the ECG.
Sir? I've done these before. So there's marked right axis deviation. Sinus rhythm PVC, marked right axis deviation. So one has got to be suspicious about
A little bit
Loud.
here, this guy. Sorry.
sinus
Sorry,
rhythm.
sir.
Sinus rhythm single PVC, a whitish QRS. Looks like it's wide enough to be full IVCD. And the marked right axis speaks for right axis for RVH. So we see what else you find. The P waves, a little generous to lead 2, but that's about it.
Here in the X-ray, we can see bilateral and diffuse linear and reticular opacities, cardiomegaly, and some calcification of the aortic arch. This could be consistent with interstitial lung disease. And here we have the transthoracic echocardiography.
We have our structural echo expert here, Dr. Larakis. If you could just take us through these images. We have a bunch of TT images and some other
So
stuff.
this is a parasternal long axis. The EF is moderately decreased. Some minimal MR from what you can see here. Aortic valve liftings are thickened, and the right ventricle appears enlarged, and most likely would decrease function. In this view, no pericardial effusion. So this parasternal again axis of the to bring in the tricuspid valve, and as you can see here, have severe, more than severe, whatever you want to call it. And Marcos will talk about TR with severely dilated right atrium and also dilated right ventricle with significant decrease in the RV function. It's a four-chamber apical, as you can see, massive differential, as you want to say it, tricuspid regurgitation. Get the feeling that the leaflets don't co-opt well. Very dilated right atrium, right ventricle also dilated. You have like a septal motion paradox movement because of high volume and pressure. And again, the LV function is moderately depressed. You have the atrial septum moving to the left, suggestive also of high pressures in the right side. So this is a great, actually great tracing for, especially for teaching. Usually the tricuspid regurgitation jet is parabolic shape with the rise and the fall of the RV pressure. And here, because you have severe torrential tricuspid regurgitation, you have a very fast, very high increase, early increase in right atrial pressure. So you have basically equalization of pressures between the right atrium and the right ventricle. So you see you have a very sharp early peak of the, of the tracing, and usually this velocity is low, less than 2.5 meters per second. When you see this, you know that you have severe TR, and also you cannot calculate the PA pressures from this because it's not accurate with the Bernoulli equation that we use to measure the pressure. So this is a very good tracing for echo boards and even for cardiology boards, to be aware of. Dr. Goldman, any for your?
We saw a couple of P waves on EKG. You don't see any atrial contraction. So important. The other aspect that I was concerned about, given the radiation history, is possible constriction. And that could be evaluated as well. And just better evaluation of the left side to see if that's the etiology of the tricuspid regurgitation. Or is looking, I know you're going to go into it, with this great mechanism.
Yeah, mostly also had the radiation and the chemotherapy, so sure she has likely myopathy because of this.
In 2017, a new classification for grading the severe tricuspid regurgitation was proposed. And Dr. Lerakis, what's the reason of this new classification for the grading of the severe tricuspid?
So basically, as you saw, you have the right side, you have a lot of volume changes and stuff like that. So, and mostly this classification was done for the trials, If you read Dr. Hunt's papers, that's why mostly was developed, because, in order to have success of the procedures that we do with transcatheter therapy, it's very difficult to make the TR go away. I mean, with the VOC valve that we talk about, it's happening, but with the clips that were, when this paper was written, it's very difficult from like torrential TR that we saw to make it, mild. It's almost impossible. You have to have perfect anatomy to do that. So in order to satisfy the trials, and because you have to have at least 2 grades of success, in order to consider it a successful procedure, they had to arrange this classification beyond severe to call it also massive and torrential. So if you start with massive and you get moderate, everybody's happy, To get from severe to mild, it would be difficult, especially with the fluid changes. So that's why that's why it happened. Dr. Hunt talks about this all the time. From torrential, have it severe or moderate, you are successful, So that's the reason that this happened.
Put another way, if you had only severe, you would always have severe at the end.
Yeah. Or if you had severe, you
No
have
trial, not effective.
You have no successful.
That's
no
the wrong
success.
answer, clinically.
Yes, exactly.
How Dr. Goldman said is also important to classify the tricuspid regurgitation according the etiology, it's primary or secondary. In this case, Dr. Leakis, do you think this tricuspid regurgitation is primary or secondary?
Most likely, no, most likely. I mean, it looks secondary, you know. Dilated annulus, dilated atrium, decreased RV function, dilated ventricle. The leaflets look okay. I mean, they don't coapt, but most of them don't coapt because of the annulus, the RV dilatation, RA dilatation. So I think it's, we have to see more views, but what do you think? What do you think,
Yeah, Dr. Contreras,
what do you think?
what do you think, and does it matter?
It doesn't matter, that this one is complicated because you have the radiation history, and the population history, you have to rule out that. You need to evaluate. I'm surprised she doesn't have AFib. I was expecting she would be AFib. Also, I think the physical exam may need to be redo because the cardiovascular exam was negative. You wanna, I think we have to look at etiologies that she can have this kind of like RV dysfunction because RV is really bad. I mean, we like MRI for RV because it's a little more specific, and we will like we'll be happy for that, and we will like to have a right see how bad that ventricle is.
Back on the exam, I would love to see the neck veins. I don't think that was mentioned in the original H&P. And I know echo is wonderful imaging overall, but I think that the exam, the cardiovascular exam, is probably very close. Saying there's no murmur, probably because it's just wide open TR.
Yeah.
And also,
There's no gradient across. So I'm assuming that the right age or right is almost there.
Yes.
yeah, and we went back to look through the chart because I didn't believe the exam to exactly both of your points. And I think if Dr. Fuster was here, he would say
I
the
was
same
just gonna
thing.
say that. That's- I'm glad he's not sitting in the front row.
Exactly. Because, you know, physical examination is so important. I think that needs to be, obviously, it's a multimodality imaging conference, but the exam has to be stressed. And going through the chart, it was a pretty stock, kind of like the regular exam that you have when you start a note every time. And that was hard to believe. So we tried to look through it again. This was not our patient. We tried to look through it. It said the same thing every time, copy forward. So this is a good lesson for everyone out there.
Either they didn't do the exam, or they didn't do the exam properly, or they didn't recognize what they saw, or they did all those things fine and they didn't document it.
Right, exactly.
Or some combination.
Exactly. All right, so we have our first audience response question. Activated. There we go. So if everyone can get their phones out, use the QR code here. We'll take you to the poll. What would be the next best test? Cardiac CT, a chest abdomen pelvis CT, a cardiac MRI, a right heart cath. I know Dr. Contreras is here, or a TEE to get a better sense of things. What would you do next? I purposely told Marcos not to show the poll. I don't want, you know, I don't like people getting their judgment clouded. You know what I mean? So, what would you say? Let's give it another 10 seconds or so. All right, we can go to the poll. Oh wow. Let's go down a little bit on the poll there.
Travis is
So let's kick it back to the panel. We're seeing that a lot of people are saying TE. A lot of go back. A lot of people are saying TE. A lot of people are saying cardiac MRI. So let's open it to the panel. What would you do next? You know, there's a little spoiler alert. Oh wow, you see that? Marcos went ahead. He saw TE, and now everyone's the. But who knows if that is the right thing? So let's see what the panel thinks. What would you do next? Start with Dr. Larakis.
Let's start with Dr. Larocca.
All right, let's start with Dr. Larocca.
Some bias.
I mean, I'm biased, but I would actually, I really want to see the right heart cath. As much as I want the MR, we could get it. It's going to take 3 days to get anyway, so let's get the right heart cath.
And definitely limiting step to get the 3 days MRI. But
That's
I
being
think the
generous.
MRI will give a picture of the myopathy and the pulmonary hypertension. That exists, but I mean, the thing you have to get all this to evaluate her. Like I will get an MRI and I will set up for a right hand cut if I think she's could be congested. That's important because if we do the right hand cut and his voice is 40, then you're not really gonna get anything. So I will try to optimize it and then do the right hand cut. And then obviously you have to do it to be able to look at it. So you have to do all of it.
The cardiac CT for the lungs. Just to show them.
Yeah. And the CT scan you have to do it for the it's a fair process.
Sounds good, Dr. Laura.
Yeah, so all this, I'm not, you need MRI, of course. But as we know, the limitations of MRI, because you don't do MRI on all these patients, but it would be good to know the pathology, to see if there's myopathy, to measure the TR. I mean, even if you don't need to measure here, you have pretty good evidence that it's torrential. But I think, because we're the academic center and tertiary center, and people get sent here to do something on the patient, So I think, in order to decide what to do, what procedure, and these are high-risk patients for many reasons. So she comes here for transcatheter therapy evaluation. So you need a TE to determine the anatomy and see what procedure you can do, clip or evoke or any other procedure.
But you want to also do the TE when she's optimized,
Yeah.
decongest, you haven't optimized
Yeah.
because the TE.
I agree.
So the team agreed with you. And so we can go to the next slide. They ended up, as we saw, spoiler alert, they ended up getting a TE, but they did optimize the patient before the TE. Okay, to your point, they did diurese the patient down. They tried to get the patient as optimized as possible. And Dr. Rockus will take us through the TE, but you're going to see that there's less TR, right? The patient's sedated, the patient has been optimized, which is really nice. So let's go through
So basically, to make a point here,
When you do the right heart cath, thermal evolution may not be a good idea. You need to do this by SAPS.
Agreed.
Too much TR.
I mean, the issue, we do TE mostly to determine the anatomy, I mean, for the severity of TR, we use transthoracic echo. So, like if we want to evaluate if the TR got better after optimization, we will not use TE, we use transthoracic echo,
Right.
For TE, we do for, to see the anatomy of the tricuspid valve and see if there's any gaps and see what procedure fits the patient, So anyway, this is, again, a four-chamber view, mid-esophageal. You can see the RV is severely dilated, severely depressed function, severely dilated right atrium. LV function is also moderately, at least decreased. No color, so you can go here. And, and we know because we do this under anesthesia, that everything is different in real life. So as you can see here, most likely also the patient was diuresed, so the TR looks, here looks maybe mild in this view, but again, we do this not for determining if the TR is severe. We do it for plan the procedure. And this is somewhere in the middle to deep, because you can see the coronary sinus coming in. And this is almost a RV flow that we use also for the procedures. And you can see that the dilated RV and stuff like that, dilated atrium. Here the TR is more moderate to severe. Next, Marcus. Yeah, again, here are the views we use. Basically, go back. So this, the previous view is a main view that we use. The previous for the procedures. Here is it's not exactly RV flow, but what we do is we scan with the X-plane, as you can see, from one side to another. And this is, as I say, soft axis is not usually you want to see the aortic valve. And we go from side to side to see where the TR is coming from. And also in the 90 degrees view, we see the leaflets. And we see if you have enough leaflets, if we decide to do the clip, that we can clip the leaflets. So this is mainly one of the main view, the most main view that we use for both dry clip and evoke. It's a little bit off axis, a little bit deeper than it should be, but this is the, one of the views that we use for the procedures. Yeah. Next. Another important view is this actually fantastic image. You can see that usually you call it tricuspid. That is 3 leaflets, but here you can see that there are like most likely 4 leaflets, and one on the side is the septal leaflet. The one in the front, because we are in the back, is the anterior leaflet. The backwards one is the posterior leaflet, and the other is the 4th leaflet, whatever you want to call it. It's a big anterior leaflet with a deep indentation. Here, Dr. Han, some people have 8 leaflets. So, but anyway, here we have 4. But this is an important view, especially for the clip. This is the view that will confirm if the clip is perpendicular to the commissure. So if we do the clip, we are in the previous view that you saw, and you have it open, and before you clip, you go to this view to make sure that the clip is perpendicular to the commissure, whatever. If you have anterior septal or anterior with posterior, you want to make sure that the clip is perpendicular before you go and deploy it. So this is a great view. And also it's to evaluate the cap. Here, as you can see, it's a very small cap. Most likely the patient has been diuresed. But these are the things that we look to decide what to do and how to do it.
So let me just ask you, 'cause I've been in the OR with you guys when you're planning these things. So just for the fellows and everyone out here, what leaflets do you usually clip when you're going to do a clip? Because I'm always under the impression that you try to do anterior and septal as much as possible. But can you just take us through that a little bit? I think that's helpful. And Marcos, can you just point out posterior, anterior, and septal leaflets here, just so everyone's on the same page? Yeah, it looks like a P1 or P2 as they call it.
It looks like most likely, or another leaflet, is, I mean, you have up to 8, 9 leaflets, No, so basically, that's why it's important. The previous view is the most important. If you have it on and here is not the perfect view, and I get this talk is not for this, but so if you see the aortic valve, and here is off, it's not a perfect view. You move the X-plane from the aortic valve to the lateral wall, and you see where the color is coming, where the Doppler, the TR is. If you see it close to the aortic valve, when you see the aortic valve, then you go to the 90 degrees and you have the septal and anterior leaflet, Then if you move it more lateral, you have on the X-plane, on the 90 degrees, the other view, you have the septal and posterior. So where where the jet is. Sometimes you have jets in both. So you have to tackle both, And then you go to the deep gastric view, go to the next. And also here, we have to put color, we don't, just to confirm. So if it's septal and anterior, you put the clip perpendicular, you put it there. Sometimes you have a large jet, So maybe you have to put 2 clips, and you start from the commissure down, and you come up. So everything depends what you see, but the most common clip is placed between the septal and the anterior, or if it's more TR left, then you can put another clip, septal and posterior. Usually you use the septal leaflet,
right,
with anterior or posterior, and you don't want to put too many because you can, change the anatomy and twist the valve, apparatus, and you may want to make it perfect, but then may cause more problems. So again, you don't try to eliminate the TR, try to decrease it by at least 2 grades.
Let me ask you one last thing. I know it's maybe a little technical. As a fellow, I always thought to myself, we do this, but then in every tricuspid clip case, they're also doing ice.
Yeah.
So why do both?
Yeah, this is a good question. And then, so basically, if you have this anatomy, you don't need ice. In this case here, you don't need ice for a clip, because the perfect imaging, When we use ice is, patients today, older patients, they have valves. They have like a TAVIs or surgical valves. They have mitral prosthesis. They have AICDs. They have devices that the Bex is shut off.
Yeah.
And the most leaflet that is shut off is the septal leaflet. So if you cannot see the septal leaflet or any leaflet, but the most common because it's towards the septum, and if you have a TAVI or mitral valve prosthesis will affect mostly the septal. You cannot see the septal, not you have to see the leaflets. So that's the way. That's the time that we use eyes. And also some people don't have good imaging. So, but most of the time is not good imaging. Yeah, not shadowing. Yeah.
That's Dr. Contreras' question is sort of the vision. We saw severe LV dysfunction, severe RV dysfunction. And we know putting clips reduce the symptoms but don't change the prognosis. It's because it's determined by what the function is. So how do you determine that we haven't, that he's not going to benefit more by better heart failure therapy, or even consideration long-term whether he's a transplant or mechanical support patient, rather than temporizing by putting, by fixing the tricuspid?
So just a little more history,
Okay.
because we only gave one line in the beginning. This patient has been in and out a lot with heart failure hospitalizations. So that has been happening. They've been going to a lot of different hospitals, not just here, all over New York. And they've been extremely non-adherent to, I don't know what the proper term is these days, but they haven't been taking their GDMT properly. And it's been a big, big issue. So yeah.
You don't want to benefit.
I'm just giving you some more context.
No, yeah, that's a good question because she had a ventricular failure. That's why I say you get an MRI. We need to realize how much the dysfunction is. We don't have the right cut yet. I had to assume this lady has some degree of pulmonary hypertension, and we had to see how much of reversibility the pulmonary hypertension is. I will treat her aggressively and maybe treat her pulmonary hypertension too, and then bring her back and see if she had anything more. But the only thing in this case specifically, she probably won't be a candidate for transplant just because she had radiation, and radiation contraindicate opening the chest and having open toxicity. But I mean, we had done maybe LVAD, but in this case, because of the RV dysfunction, she won't qualify for it. So the only option would be transplant. But given the history of cancer, pulmonary fibrosis, and radiation, she probably won't be a candidate for transplant. But if you know the GDMT, the clip is going to help.
Stuff. Yeah. All right. Do you want to go through the annulus, or we
No, I mean,
we can
yes,
skip
keep moving.
through it?
Let's
Okay.
keep moving.
So next audience response question: what is the next step now? We did the TE, we did the TEE. What would you do next? Patient's been optimized, diuresed, again in and out a lot of the hospital. So a cardiac CT, another CAP CT, an MR, or let's see how well the diuresis did, and let's see how bad the PVR and all that stuff is from the lung disease. And let's get a right heart cath, get a sense of pressures, get a sense of cardiac output, cardiac index, that kind of stuff. Not by thermodilution, as Dr. Stern said. So you think, let's give it around 10 seconds. The poll will change once we pop it up. I don't know why people do that, but it's human nature, really. All right, let's bring up the poll. Let's see. We'll see if our panel agrees. All right. Okay, it's changing. So 80%. Oh, there we
But
go.
the way it's skewed because this patient was referred for tricuspid intervention, so that's why it's skewed.
It is skewed. So 80% saying right heart cath. There's still some people who, they know it's a multimodality imaging conference, so they're saying cardiac MR. So what does the panel think? Is this the right next step, or?
Yeah, I mean, we can do the right cut. I mean, obviously the MR is gonna take a longer time, but yeah, I will want to see what her pressure is and her pulmonary hypertension. Because she has severe pulmonary hypertension for a clip, it makes things worse.
Right,
Especially with the left ventricular dysfunction.
Exactly.
Now that she's optimized. Also, yes, MRI, sure, but do we know her coronary history? I don't know.
Good point. Coronaries are fine. That's why they thought that all of this was due to, chemo-related stuff, and yeah, so it's not ischemic cardiomyopathy. For
Your
sure.
CT non-com would help you being restrictive some calcified pericardium, cardiomyopathy, and also for the extent of the disease outside the chest.
And also the other thing, she has venous thrombosis, so you have to worry about hypercoagulable disorder and part of the pulmonary hypertension. Somebody,
Yeah, just remember she was listed as being on 2 liters home oxygen. Is she now, I don't know if you know this, off oxygen with diuresis, or she's still,
Oh, she's still on.
she's still on?
actually, yes, she had lung disease, so you start thinking pulmonary disease, radiation, heart disease, so she's gonna become complex.
Exactly, that's what makes it complex. All right, so right heart cath definitely seems reasonable by the panel. And let's see what was done next, okay? So they checked the coronaries again, they're completely normal, which we knew. Let's go through the pressures, Dr. Contreras. What
And
do we
you had
think?
that, okay, look at this clear, so she had optimal, I mean, waist pressure is 10, so it's good. Area pressure is actually low, 6, so area to waist pressure is not that bad. But she does have pulmonary hypertension with the optimization, his PA is still elevated, his mean PA is more than 25, when more than 20 in the days.
Right.
And her cardiac output is low, and look at the PVR 6.7, so she has with this she has that one pulmonary hypertension.
What do you make of the RV diastolic and the radial pressure? I mean, to put you on the spot.
So it's weird because it's lower, so it's kind of similar, so kind of equalized. You look at the 10 versus it's equalized RA to RV pressure, but it is exactly the same. So there is a ratio more than 0.4 is what we look at for RV versus RA pressure. So her RV is really bad. So that means that she has pulmonary hypertension that continues to increase. And even her PA pressure is lower because she's already on the downslope of the PA pressure. So her PVR will continue to increase, but at some point her ventricle is not able to contract that much. So the PVR pressures are coming down. So people get skewed by that because you see the PVR pressure is low. You're like, oh, she has severe pulmonary hypertension, but the PVR pressure is only 55/14. But it's because her PVR pressure is already coming down because his RV is really bad. And her RV cannot mount. That was what we talk about RV coupling, RV-PA coupling. So as your PVR go up, your PA pressure goes up, your RV is contracting harder, and your RV PA pressure is gonna go higher. But as the RV fail, like in this case, your pressure is gonna go low because you don't have that RV is not able to mount that.
Yeah, so we have a slide on RVPA coupling, yeah.
Yeah, the RV-PA coupling because that your RV now is so bad that he cannot mount the pressure to build up PA pressure. So your PA pressure is gonna start coming down. So you're seeing the skew. But you look at the graphics, the skew, and then his PVR is going up. So she has severe pulmonary hypertension. And that classified as group 1, and she needs to be treated for that. And this is a good, that was a new guideline for using the TAPSI or RV systolic pressure. It's hard to use the RVs or the PA systolic pressure by echo sometimes.
You should not use. Yeah. That's what I'm saying. Yeah, you should use hemodynamic. If you have the tracing like you had here, not valid to use that. You have to use the hemodynamic systolic PA pressure. So this, as Dr. Contreras says, basically TAPSI tells you how good is the RV pressure, is the pressure that you have. So you want to have high TAPSI and a low RV systolic pressure. That if you have the opposite, that's bad. That's bad news because that means that your RV cannot tolerate the afterload, the high PA pressure. So this is coupling. If you have a good RV function and low RV systolic pressure, you have coupling. If you have bad RV and high PA pressure, you have uncoupling. So you want
very bad prognosis.
so you want to have coupling, not uncoupling.
So that's a prayer for RVs. For example, for us, for LVAD, that's a very bad sign that the patient will not do well with the LVAD. So that patient is biventricular support for a transplant, which unfortunately this patient will be
Do you do pulmonary vasodilators in patients like this during the cath?
I will have to, when I was there, some help. She has good blood pressure, so you have room to do. I will have to do it and see how reversible this can be. Yeah, because of her history too. All right.
So did they use?
No, here they didn't use, they would have listed it It would have
It's a
said,
good idea to see,
yeah, it would have been a good idea.
it should be standard in patients that you evaluate.
It really was perfect because her voice was low, so you actually, it's good. That's when you wanna use it to see if it's reversible.
Right.
You don't wanna use it with the voice is pathetic, but you wanna use it here to see if it's reversible. And also, you could have optimized cardiac output too, and see if you using the cardiac output. May have get better, I don't think, because the blood pressure wasn't that bad. So maybe it had not got better, but I would definitely do pulmonary vasodilators in this patient.
I was gonna ask, which vasodilator would you try?
90%.
So you do usually do that or?
Only we need to go, yes. We do it in the car lab all the time.
Usually it's the second row.
And
Usually
it,
says
it is
that.
what Nitricoxide would be nice because she's in oxygen, so we are healthy. And you have good voice pressure, so you won't have a problem with it. Okay. And it's easy, you inhale, you're done.
So for this patient with tricuspid regurgitation, what is the best approach? So let's activate pole.
76.
Pull it back up. Right, medical treatment. Wait and see. Surgical approach or percutaneous approach. We'll see what the crowd says, and then we'll kick back to the panel. So, what do you think's the next best for this exact patient? Give it around 5-10 seconds. Let's see. Wow. This is a medically minded crowd we have here.
Common sense.
Common sense crowd. What, Dr. Contreras, what do you think? I mean, you were kind of alluding to this, and I think that might have skewed the results. But what would you do here? You're the heart failure specialist.
I will do it, but
Should've challenged
that
you in
with
the cath
with
lab.
Nitricoxide, I will treat her pulmonary hypertension. And then bring it back, I mean, make it better, she may feel better, but I would definitely.
So you would have done like double therapy, right? Pulmonary vasodilators, see whether that helped, and go from there. But let's say you do a percutaneous approach. You were alluding to this before. Let's say you do put in a clip or a transcatheter valve. Yeah. What does the panel think about that? Will it harm her? Will it help her? We know that this patient's not very adherent to medicines, right? That's the huge issue, and that's been a constant struggle taking care of the patient per chart review. It's been really tough. GDMT, everything's been really tough.
I just don't think you have a diagnosis yet. We asked, what's the diagnosis? I know she has wide open TR, I understand that, I understand she has lung disease. Giving her a chance, or maybe someone in the hospital has for treating her pulmonary hypertension.
I mean, the thing like in this, we have some very good therapists for pulmonary hypertension. She's tough because she's 76, so is it lung standing is probably the combination of the radiation, her lung disease, although her lung disease is not as bad because it's only 2 liters, but it's a combination of factors. But we had 3 her and then maybe improve her pulmonary pressure and then bring her back to do a percutaneous approach. Definitely not a surgical candidate.
Right.
Definitely she's gonna become more symptomatic. But we had 3 here before I do the percutaneous approach. I mean, there is data on PA pressure, significant high PA pressures and failed Martha clips. But in her case, when we have the valve, but I think the clip will not be enough because the ventricle will not work for her. So you have to change the valve. Sometimes we do the valve to be able to optimize. The problem with this person, and she was in the case because her blood pressure was pretty good. Most of these people blood pressures are very tiny, so we don't have blood pressure room to optimize it many times. So sometimes the valve will help us to be able to optimize her to be able to get therapy on. Because remember, with the pulmonary pressures being with the pulmonary medicines being so hypotensive, some people have difficulty.
So if she did the right heart cath, got the nitroprusside, responded appropriately, so it's within your be the first medical treatment you would treat her for. Oh,
Yeah, you can use it, you can use Shoreline, you can use remodeling, you can use gravity, but you can, and now we have to start, so that accept that it's easy to get in. But I would have put in a lactone for RV dysfunction, maybe some digoxin to optimize the RV, and then bring it back to the.
Yeah, the digoxin is an interesting.
It's has shown some data in RV improvement. It's not clear, there's not a lot of data, but there is some data that.
Let's see.
Okay, so basically, to get the, we have a hard team, Hard team includes Dr. Contreras, the surgeon, the interventional cardiologist, imagers. So in order to proceed with the procedure, whatever we do, we get the okay.
Of course, yeah.
But
From
also
the heart failure team,
if we decide to do the valve to run the valve and also improve the medical therapy, that's the best way to be able to get this patient there.
And I think the heart team, based on reading through the notes, I think the heart team agrees with that. It's kind of doing multiple things at once to try to see if that's helpful. All right, so what happened?
So a pre-TTVR CT was done to plan the procedure, and the patient underwent to evoke TTVR without complications during the procedure. This is the evoke Transcatheter Tricuspid valve replacement. This is the valve. Here we have the fluoroscopy during the procedure.
This was the implant. I don't know why, but I just find that so satisfying. Just seeing that large valve getting implanted, and this is after it was released.
Can you tell us, Dr. Larakis, how the decision to do valve rather than clip?
Yeah, I think, lately because of the, tri-clip is, is good, but you will not eliminate the TR, as much as with the valve. With the valve, usually you have no TR left. So I think because of was torrential TR, because here also of the anatomy, I think we have put some, 2-3 clips and make it better. But because this patient most likely is not very compliant with medications, because if you put a clip, you still need to be on aggressive medical therapy, diuresis. Otherwise, the TR will come back. The clip is not. So I think the team now since we have the valve, we go if the anatomy is suitable. We go mostly for the valve because eliminates the. There is no TR left after the procedure. So I think that's why they decided to go through.
So we actually have the right there. Go down one more. Yeah, there we go. So this was the figure from the Tricuspid 2 trial that looked at these TTVRs, and it was published in the New England Journal. And I could just take you through it quickly. Essentially, people did really well from a symptom.
It was well clinically.
Right, clinically,
From
exactly.
a symptomatic point.
Exactly.
There was no mortality.
Exactly. Symptom-wise, and that's what it's showing up there. The hierarchical composite outcome was symptom-based. Exactly as we're mentioning, right? Kansas City questionnaire, and then the.
That's why the Kansas City was made.
That's what I was saying, right? The interesting issue with TTVR, and this is something that I thought, it's amazing, right? I mean, you end up with minimal to no TR afterwards, right? The procedure is, I don't know, I've been only in one TTVR, but it was a lot quicker than doing 3 or 4 clips, which this patient would have needed. Also, was a large coarctation gap. But patients did amazingly. You could see, 95% of patients in the valve replacement group at 1 year had mild or had, no TR. But there is an increased risk of adverse events. And that's something that needs to be stressed. 18 to 30% of patients in this trial, depending on how the patients were labeled, needed a new pacemaker. So that's a huge consideration. And obviously, there was a significant increase in bleeding risk, severe bleeding risk. So that's kind of the thing that you need to think about, Dr. Larakis. Anything else?
I mean, both trials for TriClip and for the VOC, they just improve quality of life. No, Dr. Coleman says, no benefit in mortality, so decreasing hospitalizations for heart failure and make them feel better. So
But you don't
I
have to
think
worry
that's
about,
important.
yeah, you don't have to worry about torrential to severe with TTVR, or torrential to massive, or
Yeah,
torrential to
yeah,
moderate. It gets rid of the,
It eliminates, yeah,
eliminates
eliminates,
it, yeah.
eliminates, yeah.
Can you also mention, because here, tricuspid regurgitation is like a pop-off protection mechanism. And what, particularly for the fellows, the immediate post-procedural handling of these patients, because right ventricle, which was using that as a pop-off, how you deal with that, what are the precautions that you take? So you can almost predict that that could be a problem.
yeah, to Dr. Goldman's point before the panel answers, you could look at the TAPSE before and after the implant, right? The TAPSE decreased significantly. We have another,
We started bad, we went worse.
yes, we started bad, it went worse, and then the RV strain also went down significantly, to Dr. Goldman's point. So
Yeah,
kick back to the panel.
What, how you handle this? This is actually very important points.
Pray.
Right?
Right now.
I pray because with this severe pulmonary pressure, you're having the critical pulmonary pressure, so you basically put a conduit into the RA and the RB. So you gotta optimize this patient. I mean, this patient probably gonna need some inotrope support, and you're probably gonna have to start some pulmonary vasodilators, and you're gonna have to keep her. If you really want this to work, you have to do that. You know, she's not gonna respond. She's gonna compare.
I mean, that's, this guy in the picture here is praying also. So that makes sense, yeah.
That's the problem with a lot of these people. That's what we talk about. Just massive dilated RA, and you just put a conduit between the RA and the RB, so the pulmonary pressure is gonna be worse. So this
Exactly.
ventricular has nothing left. So this is gonna be tough. I'm assuming she has on inotrope support now.
Well, I mean, she's home now, but afterwards, all of those things were needed, right?
Yeah, let's start on this from
Yeah.
from before we deploy the valve.
Right, they started also the pulmonary vasodilators, the pulmonary hypertension team was involved, all that stuff. So this stuff was pretty much done in concert, which, you know.
So after the procedure, follow-up transthoracic echocardiography was done 1 month after the procedure to assess the prosthesis. And we can see here the images.
Yeah, so basically, as you see, the gradient before was 1. Now the gradient is higher later, but you can see the leaflets are very thickened. Go back to this. The gradient went to 6. Before was 1, but you can see the turbulent inflow with color Doppler, and you see the leaflets are very thickened, starting from the base, moving to the tip of the leaflets. Which is, suspicious for thrombosis of the valve. That's one of the things that, critical. Look at this. It's,
What's the anticoagulation, antiplatelet
Yeah.
regimen after? When you,
So we're gonna get into that answer in just a second, because that was actually really important in this case. But to Dr. Larakis' point, we had the prior images. The gradient was, I think, 0 or 1 right after it was implanted, and now it just went to 6. And now this is on the right side of the heart, right? All right, so what do you think? I mean, Dr. Larakis may or may not have spoiled it, but what do you think is causing the increased gradient here?
Living on the best part.
Yeah, structural valve degeneration, thrombosis or halt, or patient prosthesis mismatch, or endocarditis. What do you think happened here? We'll give it 5 seconds. All right, go to the poll. Dr. Larakis gave a little teaser. There we go, 100% thrombosis or halt. So what test do you do to see the halt? In interest of time, I think we could just say CT. So a CT was obtained, and we have the CT, and we have our advanced imaging expert, Dr. Laraka, here to take us through these images.
Yeah, so really, really nice picture. You can see this is the equivalent of the 4-chamber that you would see on echo, just to orient everyone. Just qualitatively, it's at least moderate to severe biventricular size dysfunction, although you really can't comment on the LV as much because it's not as well as past by contrast. But what is striking is the extreme thickening of the tricuspid valve. And I think we have probably even a better picture in short axis. Severe right atrial dilatation there. Yeah, so now you just see
Beautiful picture.
a nice picture of the SVC coming into the right atrium, severely dilated right atrium. Really, really thickened tricuspid valve or even percutaneous valve. The RV again severely dilated, severely reduced. This degree of halt is severe. The hypoattenuated leaflet thickening, that's what it stands for. So most of the time it's secondary to thrombus. You can see it here beautifully, the cine on the right, the still frame on the left. One of these leaflets get thickened from the thrombosis. It's elliptical, so it adheres to the leaflets itself. Dr. Hahn, Becky Hahn, is probably the pioneer of percutaneous valves and has written many papers for the transcutaneous aortic valve. There haven't been enough patients for publication as of yet for the tricuspid valve, but it was a really nice study, 50-50 patients, the end of 2022, and sensitivity and specificity for halt on CT is close to 90%. A little bit of difference between systole. So this is the ideal TEE as well, obviously, but because of the situation of the right side, you just get beautiful pacifying the right side of the heart.
Incredible. To Dr. Goldman's point, the patient did miss several weeks of apixaban. And from the TRISCEND 2 trial, it says for patients receiving this TTVR valve replacement, warfarin or another anticoagulant plus aspirin is recommended for at least 6 months. And so we went back to the chart to see, what's going on. There was a lot of confusion about whether the patient needed to be on apixaban after the procedure or not. The patient was confused, and so that's why.
Take it anyway.
Yeah, right.
Huh?
He wasn't taking it.
Yeah,
anyway,
exactly. So
didn't
it
matter.
didn't really matter. But that's why, that the patient to answer your question, yes, the patient should have been on apixaban, but didn't, unfortunately. But then afterwards, once they saw this, there's multiple notes about them calling the patient saying they need to be on apixaban twice daily, and then the patient supposedly was pretty adherent to it after that. We have some imaging here. So this is the
Transcatheter echo after resuming anticoagulation.
Yeah, completely different story. Yeah,
it's really, really incredible.
result. Yeah, result.
Resolved, yeah.
Here you have the grading.
So yeah, it went down from 6 to 3, just a pretty nice change. And they also got a CT. Dr. LaRocca, what do you think?
Yeah, so just remarkable. I mean, you can see it qualitatively, the significant difference from severe to maybe mild halt. The valve now leaflets are opening much better. I think, again, you see just biventricular rotation and dysfunction and a severe. I think markers, if you show the short axis, you just get a really good idea of just, it really makes a difference with anticoagulation.
Most likely the gradient is still up because it's not completely gone. See,
Right, for sure. You can see that at the combus.
you see the meniscus there still.
At the attachment of the valves to the actual device itself. This is considered mild. You still would read it, but comparing the severity side by side, it's drastic.
Yeah, this is side by side here.
And to
Amazing.
the point that she has history of venous thrombosis, cancer, severe pulmonary hypertension, I would have had this woman in anticoagulation, and I forgot to mention for the clot valve pulmonary hypertension, you have to get a PQ scan to rule out the chronic veins in this patient before this, but this woman should have been anticoagulated before you put the valve in. So
Now it definitely.
Yeah, now, yeah. I mean, this is absolutely remarkable. Before and after a few months of apixaban. We have one more picture. I think the short axis also is incredible. The
Yeah,
incredible
it's
difference side by side.
Yes, for sure. It's still mild plus, but grossly improved.
All right. So
So
we're,
thank you very much.
yeah, that's great. So we have 2 minutes. Any final questions for the panel?
Also, any questions from the other sites?
Oh, yeah, and any questions from the other sites?
Bring up the, please.
Just to unmute and feel free to ask our presenter or panelists any questions you have. This is really an incredible case. Again, we see halts traditionally.
Looks like nobody was listening to it.
Oh, yeah. We see halt a lot with TAVR, and it's really a lot of times tough to see it because it's a much smaller valve. Here, it's a much bigger valve. You're able to see it. Yeah.
No, this is for Dr. Contreras. So you did mention previously that you would have opted for upfront medical management and not go directly to valve replacement. However, I do not remember if this patient had sequelae of right-sided heart, failure, like hepatic congestion and AKI or stuff like that. So if in that sort of patient with evidence of right-sided dysfunction, the liver congestion and AKI, would you have gone for simultaneous, fix the valve to decrease the TR and also medically optimize pulmonary hypertension? Or would you still say first approach is medical management?
Yeah, it was too bad. I would want her as my physician if this was me.
Yeah, just to say, this was done in November, right, of 2024. So we're 6 months post now, and the patient's doing really well in follow-up. And they're on pulmonary vasodilators, they're taking GDMT, they're taking their apixaban. It seems like they're really taking control of their health, and they have a very large multidisciplinary team at Mount Sinai that is really on top of it. So it's really, really great to see progression through the notes. They're still on oxygen and stuff like that, but they haven't been readmitted with a heart failure hospitalization since. Yes.
Dr. Rokas, so the pressures on the right side of the heart are obviously lower, so you would presume theoretically it would have a higher thrombosis risk. With TAVRs, we only do aspirin. The trial used anticoagulation too. What have we seen from surgical valves? Because we don't really have anything transcutaneous valve data yet. Have we seen that when we replace the tricuspid valve surgically, that there's a highest thrombosis risk because of the lower pressures, and therefore will we maybe be anticoagulating evokes regularly going forward?
We do.
Yeah, we do.
We do 6 months.
Yes.
Based on surgical valve data.
Yeah, but we do in a bulk. In a bulk, we have to go
Yeah.
for 6 months.
Also here,
I guess my point is there's no data yet. This is like one
Yeah.
in terms of how often halt happens on the right side.
Oh, yeah.
So we're
Yeah, we don't
doing
know.
it based
So
on.
the work is just, we're just starting the bulk trial, but yeah, I would be very careful. Especially with the history.
Just like TAVR was all extrapolated from congenital heart disease from the Medtronic pulmonary artery valve and tetralogy of flow. That's how we learned about TAVRs and what to do with them. And that's now we're extrapolating the data from TAVRs, what to do.
Okay.
But also look at the person as a whole. Yes, unprovoked venous thrombosis, history of cancer, severe pulmonary hypertension. Especially, I bet you should get a PQ scan to make sure she doesn't have any.
Even for the TAVI patients, when they discover the halt, because most of the time is inconsequential, you know what I mean? No problem, I mean, it's just there, but doesn't cause any problem to the patient. You start to see it after the gradients go up. But most of the studies that they did with TAVI was even in asymptomatic patients, and that's when they saw that they can be halt, So, the right side is worst, especially in patients like this with bad RV. And I think also the surgical valves, they use anticoagulation.
And in this case, you would careful fixing the right side because that one is gonna go to the left side. She already had left ventricular dysfunction. Sometimes happens with the clip. Sometimes we fix the tricuspid clip, and the MR that was moderate becomes severe because you just shift it. So sometimes you have to fix the MR, fix the left side, optimize the left side to be able to put the clip on the right side.
All right, we're out of time.
We start always from the left side and we start aortic valve, Matrapad, Tricuspid. That's the order.
Alright, thank
Skip
you
the
very
lunch.
much.